Okay, so sorry about the rain, which kind of played a spoil sport. We are actually much later than we expected we'll start, but let's start off the post-lunch session. The first speaker is Professor Samit Bhattacharya of Shivnadar University, and he's going to talk about attitudes towards vaccination, population dynamics to policymaking.
Well, thanks. First of all, welcome everyone. Welcome and good afternoon. So thanks for giving me the opportunity to speak here. And so far we have a very good kind of talk in the morning, like at the cellular level and also like molecular level related to infectious disease and like immunology. So I'll talk about the complex interactions at the population level. So the talk is like attitudes towards vaccination, so individual response in vaccination, and how this vaccination decision really kind of influence the dynamics of the disease and how it inform the policy strategies. So this is the part of kind of ongoing research themes that's going on in my lab, and my lab actually takes cross-disciplinary approach. For example, it is we use statistical tools like data analysis, parameter estimation, statistical inference theory, principal component analysis, and also from mathematical tools like nonlinear dynamics, optimization, game theory, and also computer simulation like network and agent-based modeling to kind of solve questions or answer at least part of the questions from ecology, epidemiology, and which and also its association with public health policies. And the research focus of my lab is mostly on answering kind of like how several endogenous factors like demographics, human mobility, socioeconomic status, human behavior, and also like exogenous factors like seasonal variation and different intervention strategies, drug resistance, and also in a multi-host pathogen community, how strain evolution really interact all this population level process and interact with disease dynamics, and it actually influence the resurgence of the outbreak and re-emergence of the new pathogen. So today I'm going to talk about human behavior and the vaccination. So what is behavioral response and how it influences the population disease dynamics. So I would like to start with a very famous quote by Sir Rudolf Virchow around 80s, which says that the conception of public health involving politics, medical, and social sciences. So social interaction and human behavior plays an important role in success of some public health program. For example, this is survey studies by Harvard School of Public Health in 2009 during pandemic influenza on this public views towards H1N1 vaccination. And as you see here, the majority of the population are really concerned about the side effect of the vaccines, and also they have kind of individual have misperception about the infection risk and also vaccination risk. So, but these, however, influence their decision, vaccination decision, which influence the vaccination coverage in the community, or and in turn the policy as a whole. So, what my plan today is like with a very brief overview of how this behavioral the synergies or interaction emerge into the population. I'll talk about three different stories. The first is basically the game between individuals that generates a pattern in the local population. And then I'll talk about the game between countries that themselves comprised of different population. Now, these two are basically equilibrium dynamics of these strategic interactions among individuals and or the different population. But we are in a dynamical world, and which is kind of always under perturbation, like public scare. So in the third story, I'm going to talk about like how the vaccine scare, that how this vaccine scare really influence this equilibrium dynamics under voluntary vaccination policy. Okay, and I keep my lecture very basic, like from model building, concept, model building, and simulation and interpretation of the result, because the thing I had in my mind that most of the participants were students, so at least they can, my talk can convey some message, and they can learn something out of it. Okay, so how vaccines really work. So vaccines protect the vaccinated individuals by removing and protecting them to the recovered class. And it's not only protect the vaccinated individuals, but it also indirectly helps unvaccinated by reducing the disease transmission in the population. For example, if P proportion of the population are immunized, then R0, this is the basic reproduction ratio that has been discussed in yesterday's talk. So I'm not going to re-describe all these things. So this R0 is reduced by now 1 minus P multiplied by R0. So the critical vaccination coverage to eradicate the disease is, which is denoted by pre-critical here, which is 1 minus 1 by R0, which is less than 1. And that is a good thing, because to eradicate a disease, we do not have to vaccinate each and every individual in a community. And I'm going to give an illustration. For example, we have one infected, around 10 healthy individuals. And suppose the basic reproduction ratio of this disease is 3. So on an average, 3 people get infection from a single infected individual, right? Now, if you go for 50% vaccination, now R0 is reduced to 1.5. It means on an average, these infected individual can infect only one healthy individual here. If you go for 80% vaccination, now R0 is reduced to 0.6, which is less than 1. It means disease will eradicate soon. And then the good thing is that these two individuals have very less probability to attract the disease, just because that other 80% of the population got vaccination. And this actually introduced the indirect protection, which we call the herd immunity in a group of population. Okay. And which has two different perspectives from population as well as individual. From the population perspective, it is good because you don't have to vaccinate each and every individual, and this way you can reduce the cost of vaccination, your labor, so on and so forth. But from individual perspective, this is a bit different. It actually emerges free riding behavior here. For example, two different groups actually emerged at this level, which are non-vaccinators, for example, who are free riders, basically, who rides on others' penny, and they actually gain the benefits of herd immunity, but do not pay the cost of vaccination. On the other hand, the vaccinators, they accept the cost of vaccination, but they have little bit incremental of the benefit, because the situation is near the critical level. So this is a very less incentive of the vaccinate. Okay, and so the vaccination is decision of vaccination is basically the weighing up these two different risks, is vaccine risk and infection risk, and depending on what other people are doing around you, it is to taking the decision like whether you playing strategy, whether you vaccinate, you don't vaccinate, or possibly adapting delaying strategy. Okay, now game theory, the mathematical tool, can formalize such strategic interactions. So a game can be just brief overview, 1 or 2 slides. It could be 2 players, 10 players, or population game. Here it's a population game, and we have the strategy shared. Like here in this situation, you vaccinate, don't vaccinate, or you adapt delaying strategy, and we have the currencies to measure what kind of strategy you are making. For example, here it is the morbidity and mortality from vaccination or from infection or vaccination, and you have the corresponding payoffs, like what strategy you are playing in the population in terms of this currency. And we have two assumptions basically here. So in this game, we generally assume that all individuals attempt to maximize their payoff and know that what others are doing likewise. And we also assume the second one is that all individual rational. Maybe here I should point that this rationality assumption is not always accurate, but it can serve as a useful starting point and can provide as a benchmark against which we can compare the actual behavior in the population. And different kind of solution concept can arise in this game depending on situations. Okay. So now I'm going to talk about the first story, like the game between the individuals and that generates pattern in the population. And the story is like the individual has to take decision in face of a disease outbreak, say influenza outbreak. So this is the same study by the Harvard School of Public Health. Only to note here is that the individual has concerns about several things like side effects, disease infection risk, and also kind of concern about getting H1N1 from vaccination. So in that situation, individual actually adapt wait and see policies here. And there are two sorts of strategic interaction in this policy. Like there is a probability of infection that declines with the more individual vaccinate and herd immunity develops, as I described here. And there is also another thing, which is the perceived vaccination cost, which is initially very high, because in most of the cases, basically in influenza thing, your vaccine is new and it is not tested for a large population. So, but this cost or the risk actually declines as more individual vaccinate, and the safety for information of the vaccines actually spreads over the population. So the question that we are asking here in this part, that how these two strategies interact with each other and that impact the outbreak dynamics, and what is the implication of the risk communication during an outbreak. Okay, so here is the model formulation. So here is the outbreak, and where the entire time period I took here in this kind of study is 1 year, which can be shortened. It's not it doesn't matter too much, and divided this whole time period in weeks here from 1 to 52 weeks, and individual and vaccination is once per week, and individual have a kind of choice, like whatever the week they want to vaccinate. So the phi here is this phi k is basically the fraction of population that choose vaccination in the week k. So along with this advanced vaccination and no vaccination, we have basically 54 strategy that individual can draw here. And we have, so if we put in game theoretic setting, so we have altogether 54 strategies, and we also compute here. So this is the phi set here. These are 54 strategies, as you see here, including advanced and no vaccination. And we also compute the payoff for this strategy. So L is basically here, as you see here, this phi of phi k pi is L here is the baseline payoff in absence of vaccination and disease. And for example, this advanced vaccination individuals, so they have the risk of vaccination and as well as risk of infection for the individuals whose vaccine didn't work. So phi epsilon is what you see here, the R in rho here. Rho is basically the probability of the infection. That will come in a minute. And this is phi is the efficacy of the vaccination. So this is 1 minus phi is the population which are vaccine didn't work. So they have the risk of infection. On the other hand, if you see the last line here, who are not choosing vaccination throughout the entire period, they have only to enjoy the risk of infection. So the rho here is basically the probability of infection, and that we compute using SIR model. It's a 4-compartment model here in this case, so susceptible, infected, and recovered model. And SVAC is basically the group of population for whom the vaccine didn't work here. So we compute the probability of infection at week j, and it is the sum of the probability of infection all 7 days in a week, and that we compute using this model and also using this strategy. So, and hence the cumulative probability is up to week k. Okay, so using this baseline setup, we have another component here that we discussed. This is that perceived vaccination risk actually declines with cumulative vaccination coverage. So what you see here, that A by, in this figure, right hand side, this A by, okay, maybe I can tell you this R AC, VAC, the R-ACVAC is basically the actual risk from the vaccines, which is not known to the every individual in the population. So A by R-ACVAC is the threshold where this risk of vaccination, perceived risk of vaccination, actually meets the actual vaccination risk. So higher implies slower the decline in the perceived risk to align the actual risk. So this is the setup that we are taking, and with this SIR model to describe the disease. And what we do is we compute the Nash equilibrium of this game, and we use simulated annealing algorithm to compute the Nash algorithm equilibrium of this system. And what we see here results is that in the left figure is for different values of A, how this vaccination coverage, disease incidence basically goes. As you see here, this higher is the value of A, means lower is the vaccination coverage. As you see, as is very much clear from this non-vaccinator proportion here, the higher is the value of A, means higher fraction of population going for non-vaccination. So instead, if the actual vaccination risk is known to the individual, as you see that there is a high vaccination coverage initially in the population, there is lower in the disease prevalence is this thing. So the implication of this result is if individuals are informed about the disease actual risk of vaccination, in the beginning, the risk declines faster and increase the vaccination coverage. So we also take another experiment with this, which high initial vaccination coverage denoted by this 0.004. All are scaled parameters, so we can really play around with all these things. As you see here, this higher is the initial vaccination coverage, lower is the vaccination coverage throughout the outbreak here, which is again kind of indicated by this non-vaccinated group, and that risk of vaccination actually propagated throughout the outbreak here. And here is some feed-forward mechanism basically working. As you see here, well, yes, so the feed-forward mechanism means, so here is high initial perceived risk means lower vaccination uptake in early week, so less safety information available, and that actually propagates throughout the whole outbreak. Less information means less vaccination coverage, so at the end we get lower cumulative vaccine uptake. So here basically our media can act on this. A can be a function of media or some vaccine campaign, where we can see that how vaccination, I mean this media or vaccination campaign can really act on in individual decision making process and help in vaccination coverage. In fact, well, so that I described. So here is one of the report I got.
Samit, I have a question regarding the previous slide.
Okay.
Presumably, these are averages over multiple realizations of simulations, right? I mean, because you have lots of fluctuations.
Yeah.
So I'm just wondering, what are the error bars? Because you mentioned that 0.007 has lower coverage than 0.004, but if I include error bars, for example, would these differences be significant because the curves appear to be very close to each other?
Well, the thing is that that is why, like for example, it's really difficult to make out from this time series here of the vaccination coverage. That is why I put side by side here the non-vaccinator. So what is in the end, what your total number of cumulative vaccination coverage and what is the proportion of non-vaccination. From here it is, you can really make out is that there is a difference over if you initial vaccination risk is different. The model actually I took is a deterministic, not really a stochastic model. But you are right. Like if we could take stochastic model and experiment over different realization, and we could put error bar, that might be better indicator to kind of conclude this statement. Yes.
Like things are not showing very monotonic behavior. They're waving around a lot. So presumably there is some initial condition.
So as you see here, well, the time scale also I have taken here is week, not really kind of days things here for this vaccination kind of coverage, because we divided the whole time span in week and vaccination in once per week. So possibly more continuous scale of this vaccination coverage will give some kind of better indicator of this thing. But the ultimate thing is that what we are kind of ended up with the cumulative vaccination coverage, like non-vaccine, I mean, depending on different initial risk of actions. So this is the report actually came out very recently, and from the vaccination effort for this H1N1 in India. And these blue peaks basically tells the cases of H1N cases in India since 2009, and we have the maximum cases this year. But the cutout says, the paper cutout says that the government has to intensify the information and education campaign much before the peak season occurs during June. So that's the thing. So like maybe I can show you here, as you said, that the result emphasizes that risk communication in the beginning of campaign is more useful than in the middle of the outbreak. So that is what this result shows. So initially, if we can spread that whatever the vaccination risk or actual kind of disease risk, that is much better than campaign in the middle of the outbreak, more effective here. So in a summary of this thing is that wait and see attitude in the face of declined vaccine risk interacts with disease dynamics through several feedback and feed-forward mechanisms, and imparting accurate and useful vaccination safety information, especially before this outbreak, is much effective than during the outbreak, especially when vaccine is new. What happens in kind of vaccine for influenza kind of disease. Okay, new strains we get and new vaccination. Okay, so now I'll move to the second story here, the game between two countries that themselves comprised of different population. So like this individual behavior, like in the local thing, it can also influence the disease the global scale disease dynamics and its policy making there. So here, for example, like whose measles and rubella elimination goes. There are several challenges here, as you see here, that high population density, especially in developing countries, high mobile populations, developed countries things, and also weak immunization hardened system, for example, in developing countries, and also is the managing perception and misperceptions perceptions about the disease, and also kind of the vaccines things, especially in developed countries, for example, because of high nutrition, healthcare, this individual have many citizens, like they no longer persist measles and rubella as a serious problem, and because the mortality rate is such a low there in developed countries, and there are also financial risks, and along with that there also challenge in for the third parties, non-governmental third parties. For example, BCG Foundation, like Bill and Melinda Gates Foundation. So they actually contribute crores of money funding to vaccinate and eradicate this disease in different countries here. So how to optimally deploy their funds among countries to achieve this global eradication in the face of this vaccine exemption. So I developed a multi-country game model, basically two-country game model, and we'll see how this individual decision in this voluntary vaccination policy really impact this policy making and how dynamics works here. So before I go into that, I'll take some time to talk about how the behavior prevalence model basically developed. So in this behavior prevalence model, individuals basically sample and observe other community members in the population, and if which is called social learning. And if the sampled persons is playing a different strategy and receiving a higher payoff, individuals switch to that strategy with a probability proportional to the expected gain in payoff. And that has been observed in different, social media that actually encounters this kind of thing, discussion things. Okay, whether your children is getting that, are you getting risk, or individual are learning from that and taking a decision. So this has a lot of influence in decision making thing. So here is the behavior model. So behavior model denoted by X. So X is the proportion of the vaccinators, and that actually describes how this proportion of vaccinators basically evolve depending on the payoff, which is comprised of the risk of vaccination denoted by CV here, and also the risk of infection, which depends on your disease prevalence here. And delta is the sampling rate. So this kind of model can describe, so X is basically the proportion of vaccinators, so 1 minus X is non-vaccinators here. So depending on your payoff, like when it's positive, it means the risk of infection is high, there's a lot of incentive to vaccinate, so this proportion of vaccinator will increase. And if it is negative, this proportional decrease, it means there is CV's risk of vaccination is high, and the risk of vaccinator will decrease that way. So this kind of model can describe this what is free riding behavior of individual in the population. Okay, and for this kind of two-country game model, we have another complexities in this payoff. First one is that we assume that government supports vaccination, and we assume that it is in proportion to the country level of infection prevalence in the country. For example, like which country has more prevalence, support of government is much higher in that thing. So it is denoted by this term here, which is proportional to the prevalence here, and the D actually denotes the amount of third-party budget, and there is one parameter here, E, which indicates that how one country is successful in deploy their funds in this vaccination campaign and successful in success of this kind of policies there. So here things comes basically where we take two different countries with different GDP rates. So for example, if one country has higher GDP, then they have basically, they actually buy less incentive. So E is really very low for them for developed country. For developing country, their GDP is less. So with the same D, they actually buy more intensive here. So we add this complexity in this behavioral model and scale this up, and we kind of couple with disease model. So here is the full two-country game model, country 1 and country 2, and there is a part of disease model here, susceptible and infected, both here, and they have also kind of migration between these two countries, and they have also case importation, which is a very low rate here. So with this two-country game model, we take parameter values that reflect measles in developed kind of disease here, and developed and developing countries. This situation two different GDP here. That is kind of give kind of contrasting results to interesting to look at. So what we see here is that increasing the budget allocation to this developed country has higher effect in this country too here. As you see here, the vaccine uptake after some threshold, the vaccine coverage actually really goes very from 100% to approximately 0% here, and also disease incidence goes high here. And compared to that, this country 1, whereas GDP is very high, there has not much effect, except there's some oscillations into the prevalence and in the vaccination coverage. So it's a kind of local behavior in this thing. So average behavior is pretty much same, and this is happens because of this. They buy less incentives, not really too much effect, even if you change the budget towards the developed country. Okay, and the more interesting result is that kind of apart from this from the base parameter values, we are able to find a parameter regime where you can see that this kind of region where this budget allocation really minimize the disease in the two countries, where you can say that when D is less than 0.5 means there is no disease for the country 2, and for D is greater than 0.6, there is no disease in country 1. So this is the region where probably we can optimize our model, and we can get a value where it is possible to kind of optimally deploy our funds among these two between these two countries to get kind of control this disease incidence in globally, or eradicate the disease. So this gives a very kind of contrastive picture using this thing, though it's a basic level. The higher level result I am not showing here. So in a summary, that optimal allocation of the third party fund between two countries to eliminate the disease, where each country's government incentivizes vaccination according to the disease prevalence, and the cost may be more complicated. Like here we have taken only this vaccine risk, and also the infection risk, which is proportional to the kind of prevalence. But it could be, it's possible to make it more complex. Like we can make it a function of disease campaign, kind of developed and developing countries, and you can see that what are the impact things, and also like other demographic factors, and how it impact this getting this kind of optimal distribution of the fund among countries to eradicate the disease. So now I'm going to talk about the third story here, the vaccine scare. And how really influence the vaccination coverage under voluntary vaccination policy. So, this vaccine scare are getting more common and common as this eradication goal is approached. For example, like polio was on the verge of eradication in 2003, but the global resurgence of a vaccine scare in the Nigeria's northern state Kano that caused the global resurgence of this disease, and it was mainly because of this Muslim community in this state. Actually, they boycotted the oral polio vaccine, and the rumor was that WHO's vaccination campaign was a plot to reduce the number of Muslims. So this kind of scares are not very specific to polio or even the problem with developing countries. It is in fact a problem like the global. For example, here this animation shows the global resurgence of early childhood diseases. For example, here this measles, mumps, rubella, and along different developed and across developed and developing countries. And all this has link with the change in vaccination safety information. Rather, what I should say, with perception about the vaccine safety in the individual thing. So here I'm trying to understand that how what are the basically key determinants that really govern the individual decision making in these situations. And there are two things that we have described here in this behavior prevalence model. One is the severity of the disease and its prevalence in the population, how it really impacts in decision-making process, and also the social learning. And the question that we're asking, that does the disease prevalence feedback on individual vaccinating decision during a scare? Because scare is kind of a different thing than your equilibrium dynamics. So far I have described in two other work, they are basically equilibrium dynamics, and this is a kind of perturbation of this equilibrium dynamics. So it's a very different kind of situation. And how much social learning is important in individual decision making during a scare. So to test this thing, we are basically taking two different data sets here, which is measles, mumps, rubella vaccine coverage is denoted by the black curve here, and this is the incidence here from 30 years and in England and Wales, and I'm taking the part of it here from 1998 to 2008 for 10 years, and also there's another data sets here, which is the Pertussis vaccination coverage in the England and Wales, because that's the place where we have seen the vaccination details. There's a lot of vaccine scare had been there in this developed region. Okay, and I'm choosing this to kind of part of this for this both kind of vaccination coverage, because these two parts captures this subtle dynamical change in this vaccination coverage, and also like in this range there is no immunization program actually introduced, as you see here, because otherwise it might affect our result to test the result. So zooming this to data sets, we have the Pertussis data set vaccination coverage and also MMR scare for this 10 years. And our objective of this work were whether a behavior incidence model, including these features like social learning and feedback, can explain this to vaccine scare better than other model. Kind of, I'll explain in a minute what other model means, and whether this model can predict the observed vaccination coverage during the scare. Okay, so I'm taking same behavior model that I described here, this including social learning, sampling rate, scaled it is again, and this payoff depending on the risk as well as it is on the severity of the disease prevalence. And I'm getting other models, sub-models from this here, like social learning but no feedback, no social learning feedback, and here is the simplest one, that no social learning and no feedback, simply from the risk of this vaccination, the risk of vaccination and infection. Okay, and we have taken the different the risk evolution curve, and we are considering the mechanistic, not mechanistic, phenomenologic curve to describe how the risk evolves, because we do not have mechanistic risk evolution curve, especially this kind of situation, how risk evolves in the herd. So, and it has several parameters. The risk is stable here. After that is increasing it increases at some point and stays stable to some time, and after that it decreases to and match with the pre-scale level, and described by 4 parameters. From there, I'm choosing different submodel of this risk evolution curve, and you see it described by different parameters. This kind of from the pre-scale level, risk increases. After that, it is decreasing linearly to match the pre-scale, or risk abruptly just increases and decreases here. So different situation, like you can think of that this kind of risk evolution in the population is a result of like vaccine campaign or whatever, how media is act on. Okay, so the 5 different curve and 4 different models. So altogether we have basically 20 models per se to test like which one really describe or this vaccine, the vaccine scare better. Okay, so and we are doing our experiment in 2 different phases. So we are taking that individual make decision based on empirical disease incidence, like we're using actual disease incidence to kind of understand how severity really having feedback in this system, and we also see how this feedback from a model, from the model, like using SIR model in the phase 2 experiment. How it impact the describe the situation vaccine scare in this thing. Okay, and we use statistical inference theory here to describe thing, and to in parameter estimation thing. And I'll describe only the phase 1 case, like where I'm using disease incidence, actual disease incidence here to describe the result. And as you see here, the for Pertussis, so left here the different model here, social learning and feedback, and social learning no feedback, no social learning feedback, and here is kind of null model, you can say no social learning, no feedback, and different kind of 5 different curve here. So as you see here, this row basically the red one is model fit, then black one is the data. As you see here, the vaccine coverage is better described in most of these different kind of risk evolution curves in the first the model, where social learning and feedback has component into the mechanistic model, the part of the mechanistic model. Whereas when there is no feedback, the vaccination coverage goes down as the scare appears, but it doesn't go back, and it is kind of terrible when there is no social learning. And for no social learning and no feedback, this is also kind of same, except this one is doing maybe the best among all this. And there's a reason thing that I'll describe. So if you see the data, for example, here, so if you take all the undulation from this data like this small oscillation, this can be described by 5 different kind of points here. The 5 different data points can describe this data, and the model with social learning, without social learning, and without feedback, and with curve 5 has exactly 5. If you go beyond here, you see that curve 5 has exactly this 5 parameters to describe this thing, and that's the reason kind of why it is describing very well. So there is no mechanistic kind of process that really working here behind this to describe these things. So that's why we say that only the model social learning compared to that, for social learning model with social learning and feedback describes for all different risk evolution curves. So this we take as a better candidate for this selection methodology. And same is here, like for example measles, which is you see, the model is social learning and feedback, you see, is doing better for all these 5 components here. So now I'll go with this predictive behavior. So to test this predictive behavior, we take this, now we have this one model we can understand, and also like the, okay, let me tell you, just quickly tell you, as you see, these numbers are basically this indicator of this from the information criteria, especially where we have used AIC, archaic information criteria, to test this model thing. So this you see, these numbers are really kind of doing better compared to all these things. Higher the negative values is, the better is the model. We use some likelihood inference theory. Okay, so we use here for the predictive behavior, we use this imitation feedback model that including social learning, and as well as this feedback from the disease incidence here. And we use only curve 1 to predict this thing, because other curve has multiple decision points depending on first vaccination history, which is difficult to get it. So that is why for prediction we use only the curve 1. See. And the way it is working is that we feed the disease incidence for t equals a different time point, and we see using probabilistic analysis and also like bootstrap method how it is doing good in describing the data ahead till the end of this data we have. So we use that I told you. So here is the result, as you see. For example, the data can describe, for example, when t feet is 1977, and after that it's describing thing, and you see several simulations here, and it can capture this several peaks in the disease incidence, all these things. And this predictive thing abruptly changes when t feet is 1978. So this is, here is the peak. So this is the peak actually provides a lot of information, so that it collapses a lot of uncertainty here in this in the data set. And it can also this one, and well, increasing t feet here also has better feet compared to this here prediction here, and also describe the undulation here. So the blue one basically, blue one is the fate, and this is the red one is different realization of the simulation, and black one is the data here. The measles. So t fit is basically the, for example, t fit is 1978. So we are fitting up to t from initial to 1978 year, fitting the data. We are getting the parameters from the model, and we are using the parameters to predict the future thing.
Mismatch at 1974 doesn't make sense, right? Because you're fitting the data from 71 to 81. So why should there be such a discrepancy in 74?
So you mean
from the bottom figure, if you if you see that there's a big mismatch between the prediction and the actual result in around 1974-75, right? The one that you have circled in blue.
Yeah, here.
No, the one that you have circled in blue.
Okay.
The bottom figure. But that's the part where you have done fitting. So why should there be such a big mismatch between the predicted and the actual?
That's why, because when you increase the time span of the fitting, probably model is taking effort to feed this part of this dynamics, rather than, it is all depends on how the model will take this fitting.
Right,
so,
but I thought you are fitting between 71 to 81. So, like it's kind of completely counterintuitive that you don't.
No, it's like, so what I'm saying is that from in all three rows, we are fitting, say initially it's 1971, from 1971 to 77 for the first one. Here is the time series in the second column. I'm fitting 1971 to 1978. Here is 1971 to 1981. So depending on like how your what is that? What is the indicator for this fitting? This least square approach I have taken. So how it will minimize the model. So model will minimize the distance from the data. So if it thinks, that is what has happened. Like for example, instead of fitting this part in this case, gives minimum error fitting this part. So when you increase your the time span of fitting, so this gives lower R square. Or beta R square, whatever it's beta R square to describe this data.
Sorry, Shamit. I mean, I simply don't understand. See, you are saying that you are fitting the region between 71 to 81. Okay. So I would have understood if you have good agreement between the data and your prediction from 71 to 81 and less agreement from 81 onwards. But you seem to have exactly the opposite. See, if you don't have good agreement in either 71 to 81 or 81 onwards, it's fine. Okay, I can understand that. What I find completely counterintuitive is that the part that you are actually fitting, you don't have a good match, and the part that you don't fit, but which presumably comes through the parameters, you seem to have a good fit. So how is this coming about?
So that's the thing. So what I'm saying is that when you increase, the time span of this fitting, like this is, for example, like 6 years in this time span. Here it is 7 years, and here it is kind of 10 years or something. Okay, and it's different. Like I'm fitting both of these things: disease incidence as well as vaccination coverage. So this what is called the minimizing the error I'm taking. This is it has different weightage. So it is like, for example, disease incidence and also this vaccination coverage. So it actually depending on where the model will work in that way, like where this is minimized, this thing. For example, here is compared to this one, second row, the third row is giving less amount of the error we are getting for this thing. That is why you see this result. But here, a lot of information I'm getting, so this is the predicting is better. Maybe we can discuss this thing. Okay, and for this measles is more challenging because measles there's this low volume of vaccines coverage decreases less, and also low volume of lab confirmed cases. So there's a lot of challenge there for measles also. But we can see that our model can predict this kind of the peaks, timing, and kind of oscillations. You think in the disease incidence thing. So, but still we see discrepancies, and the reason because is underreporting of the cases, which was very common in early days, and also we use very simple model here of this thing. In the transmission, we should include kind of stochasticity thing, age, structure, and serious outcomes, and this might have an effect in how disease spread and vaccination things. And of course, we use phenomenological curve. If we could use mechanistic risk evolution curve, that might have some different better influence on this conclusion thing. So in a summary, we see that the social learning is necessary to explain the resilience, like how in the dynamics of a scare, like how the scare actually evolves over time. But feedback from this disease prevalence is essential to recover the coverage from this scare. And studies suggest that this proper risk communication about the vaccines and disease severity or prevalence during a scare might help slowing the decline and also increase the vaccine coverage during a scare. So wrapping up now. So we know that for this disease eradication, it is the goal of public health policy is to maintain, it's to achieve the high vaccination coverage and maintain it. We all know that it is hard, but my model show at least like why this is hard and what kind of complexity and synergies can really emerge in this kind of human behavioral response and its interaction with the disease spreading, etc. So combining game theory and transmission modeling, this allow formalization of this behavior infection dynamics, and it can change, describe the changes in individual perspective on vaccination behavior. It can capture the endgame policymaking at the global scale, and it can also explain the dynamics of kind of public scare So it is due to this inherent instability of their voluntary vaccination, and this not just historical events. There's some kind of mechanistic process going on in the scare during this scare. And this kind of modeling practice might help to mitigate the impact of vaccine scares and assist planning in global and eradication endgame. And of course, game dynamics model can serve as a predictive tool for cost-benefit analysis in the face of such strategy interaction and inform specific policies in health economics. But what we really need these days to more kind of association. So far, the work we had for this vaccination game here is mostly theoretical, like different kind of model formulation, different hypothetical, the effect of different hypothetical conclusion, and really very less work on its association with the data. So we really need to integrate with this kind of study with this empirical data like vaccination coverage, disease incidence, and possibly other social interaction data over network and things. So here are some of the publications that I talked about, and there's a little bit ad for the students for the PhD program and project close. I'm taking up students, and for these 3 different projects, drug resistance and like these social processes into behavioral models. So we use different models, and we also have project on evolution and emergence of infectious disease on like different social structure and using network model thing, and different kind of fellowships are there, CSE, NET, GATE, NBHM in India, and also SNU has competitive fellowships like same kind of 35,000 per month, which is competitive compared to this thing. So just write to me for this with your CV and one-page research interest. That would be yeah, great. So here are some of my collaborators for this disease, and some of these funding agencies when I was abroad and did this work. And thank you very much for your attention. Yeah.
Just the very last one. The last slide. Very last
Oh,
sorry. The very last slide and the very last point in the last slide. Not even that.
Here you mean?
Yeah, very end. So yeah, just one before. Yeah, just one before. So you're mentioning about, you have present a lot of like theoretical developments in this particular area, and you're kind of mentioning about how you like to integrate with other empirical models. Can you think of like particularly studies moving forward that you like to apply these models in the future? Like, can you think of like anything like that you have in mind to apply these type of game theoretical models, behavior infection dynamics, for future that could be useful for policy making, especially in the context of
yeah,
India?
like like I said, because we have a review in what is that? Okay, maybe I'll tell you later. I can remember that. So this review actually take up. There is also a chapter like that describes all this thing like behavior prevalence model, and there are belief-based model on network, and also population. I mean, like homogeneous population, what I have described here. But it's a very less work on like how we can integrate with the data thing. There are very few work on, for example, like one component, if you think like how this information spread. For example, there is a vaccination component, or even like this safety information of the vaccination, especially when the vaccination is new and in the face of influenza outbreak. So in a community, if you really have the data like how this information actually spread in a community, that we can possibly integrate with the model and kind of you can see that how it's really impact the vaccination coverage kind of things, So there are a lot of other things that we can couple with a disease model and also, but all at population level process, whatever it is over a network or over homogeneous population. So this we need to understand this thing for get better information to apply this public health strategies.
Further questions? Shamit, in the slide before this, you mentioned that you could model vaccine scares. I was just wondering, how exactly would you do that? I can understand the game theoretic setup in which you try to figure out how some individuals would rather go without a vaccine and just ride on others getting vaccinated. But how do you actually model the onset of a vaccine scare, which is like a collective phenomena spread across many individuals? Your last point. Yeah.
Well, that is. I understand what you're saying, but like for example, this is one formalism, like my last work explained. Like we, the main challenge is like is how do we model how risk evolves? For example, the challenge is how risk evolves, and that is why we have considered only the phenomenological curve, different curve to describe this how risk evolves. So there's a lot to do with this how perceived risk and risk kind of spread in the population and how it interact with the contact pattern of this population thing, and this is really challenge. But otherwise, like we can kind of couple behavior influence model to get some kind of sense that after this scare how it really works. For example, vaccine scare has two parts. If you notice that, like the scare, when this scare actually started at some time point, which was kind of our initial point of this kind of experiment, and after that it takes really very the sharp decline, very less time to go from, for example, the Pertussis one, it takes okay, maybe if I go to this here, so it takes only kind of 4 years to go down from 0.8 to 0.4 or something like this, 0.3. But it takes a lot of time to recover this process. So here with behavior preference model, we describe this thing basically, not really how the risk. What is the actual risk and how it's working, that we don't know. So that is one challenge here that I kind of agree with you. Like once the risk comes, depending on something, so how spread in the population, how population react things. So that is the part of thing and challenge in this working in the human behavior and its impact on the disease dynamics.
Okay, so if there are no further questions, let's thank the speaker once more. So we break for coffee, and can I request everyone to come back within 15 minutes because we are currently running more than half an hour behind schedule, so we want to finish